only mode.
Welcome everyone, and thank you for joining us today for our webinar on top documentation challenges from a compliance perspective. I'm Kathy Ransom. I'm the Industry Education Coordinator here at TriTech, and I'd like to introduce you to today's speaker. Today we have Steve Johnson with us. Steve is the Director of Reimbursement Consulting with Page Wolfberg & Wirth and works extensively on billing and reimbursement related activities, performing billing audits and reviews, improving billing and collection processes, providing billing and coding training, conducting documentation training programs, and performing many other services for the firm's clients across the United States. You can read his full bio on the PWW website at pwwemslaw.com. And now I'm happy to hand it over to Steve.
Okay, thank you, Kathy, and thank you to TriTech too for providing this opportunity to get together and talk about some things that we at PWW see way too frequently causing trouble for ambulance services as we perform claim reviews for them and as we travel around the country doing documentation, billing process assessment training. We always enjoy the opportunity to work together with the good folks at TriTech, and I want to especially thank Kathy and Sherry for all the work that you two have put in making this webinar possible today. We've got a lot of information that we're going to pack into the next 60 minutes, but before we jump into it, we've got a couple of quick housekeeping items that we need to cover. First of all, I guess don't steal our stuff. Secondly, don't steal our stuff. This webinar is being recorded and will be available for future viewing, but recording by anybody other than TriTech or PWW today is prohibited. Information today is presented for educational purposes. This is not legal advice, clearly, since I'm not an attorney. How could it be? But just want to make sure that everybody understands. This is an educational session, and no kinds of protections or legal advice issues apply here. Any examples that we might use are exactly that, examples. We're not giving templates for how your documentation needs to look and so on. And also, make sure that you work within your own organization to implement any changes before you implement things that you may hear today. In other words, you might have to check with the boss. Just because we said so doesn't mean that your policies and procedures go out the door. So with that, let's jump into it here. The first question that came up as we started planning this one was, well, who's the target audience? And really, the target audience is you, whoever you are. And all of these different job functions are important to the topic today. Really, the compliance problems that are caused by inadequate documentation and by the billing decisions made in reliance on those documents impacts everybody at all levels. And everyone in the organization really needs to do their part in taking responsibility for your organization's compliance efforts. In other words, organizational compliance shouldn't be seen as just the responsibility of the compliance officer. It's really a team effort, and the entire team either succeeds or fails together. So today we're going to take a look at some challenges related to both patient care documentation and claims preparation, not as separate and unrelated tasks, but rather as a team effort to help ensure organizational compliance. So the goal here is this. In many organizations, this is perhaps the biggest challenge we see with regard to organizational compliance, and that is teamwork rather than an us against them mentality between different departments of the same organization, for example, the crew versus the billing office and so on. So we'll take a look at the importance of excellent documentation and its impact on the answers to these two vital questions. Will I be properly reimbursed for the services I provide? And even more challenging than that, when my claims are audited, will I be able to keep the reimbursement I got for those services I provided? In case you haven't heard of it yet, you need to be aware of CMS's fraud prevention initiative. This comes directly from the CMS website. And they clearly state that they're moving beyond a pay and chase approach, which is really what it's been in the past. You sent in a claim, they paid your claim, and then they looked at it later to see if they should have paid your claim. But they're really looking now to prevent those bad payments up front. This initiative resulted in $4.2 billion of payments that were made being recovered just last year alone, and they promise even more aggressive action. Continuing on from their website, that's pretty good return on investment there, $3 for every dollar spent in the first year of the program. Pretty good ROI. So if I were a betting man, I'd bet they're going to continue and probably pour money into something that has that kind of return. Often the biggest overpayment demands that we see represent, as the slide says here, not just a single point of failure, but rather a failure on the part of the entire organization to maintain a climate of compliance everywhere. It's vitally important to your organization's financial survival in today's regulatory environment that you maintain within the organization this climate of compliance. It's sometimes apparent that patient care reports are seen by some as simply a laundry list of tasks that were completed with regard to a given patient, rather than as the primary document that establishes the fact that your organization provided a reimbursable service in compliance with the requirements of the appropriate payer. Sometimes it seems that the PCR is seen simply as operations, an operations document, somehow unrelated to the billing office's job of getting paid. And it also seems that sometimes the feeling from the billing office is, well, I just have to work with what I get. Whatever the crew wrote, I've got to bill based on that. So what should have been a properly reimbursable service had everyone within the organization taken responsibility for seeing that all the I's are dotted and the T's are crossed. Instead, it becomes a major compliance risk to the organization simply because somebody failed to ensure that clear dispatch protocols were in place, that dispatch did a poor job of communicating perhaps to the crew, and the crew didn't document it so well, and then billing takes that documentation and runs with it and submits a claim. Folks, that's the perfect storm of compliance risk for your organization, and it's one that we quite frankly hear the results of all too often. There are several opportunities for checks and balances, and most often that failure to either be properly reimbursed or to be able to keep the reimbursement you received is a result of a failure at so many different levels. When you're not fairly reimbursed, or when you have an issue with a recovery, every department in the organization should be involved in reviewing the processes to figure out why this happened and how do we prevent this in the future. And I'd like to suggest that your organization view its compliance with regard to claims submitted as a series of periods of control, each with its own opportunity to ensure that the claim that will result will be a claim that's had its compliance with the requirements documented every step of the way. Now, the last three on this list represent indirect general control opportunities and responsibilities, but the first five represent an event in the life of every claim with specific documentation needs and responsibilities. So we'll look at some more specific issues in these areas with regard to emergency and non-emergency transports in a few minutes, but it's important to understand that a failure to submit a clean claim in compliance with the regulations of that claim is often not the result of a single problem in just one of these five areas, but rather a problem that was initiated early on and was allowed to continue down the path toward claim submission when it should have been easily identified and corrected. And also, in many cases, that claim can represent a failure on the part of the last three on the list to provide adequate, regular, ongoing training and oversight to prevent the problem in the first place or properly identify its cause and prevent its reoccurrence in the future. Folks, it's way past time we stop accepting the excuse that we hear all too frequently, that's not my job. The message needs to be loud and clear. Ensuring compliant, clean claims is everybody's responsibility. So first, let's take a look at a few critical areas where we frequently see compliance problems in the claims that we review. And the first one, of course, medical necessity. And so we're going to look just real briefly. I'm not going to belabor all of these regulations, but they're here in your handouts because these are the things, the basics that we need to not forget. Medicare covers ambulance only if all other means of transportation are contraindicated. And that is the definition of medical necessity. It's interesting to note a group known as MedPAC, the Medicare Payment and Advisory Commission, recently recommended that Congress instruct Health and Human Services to more precisely define medical necessity requirements for both emergency and non-emergency ambulance services, including the development of national edits to be used by all of the MACs, so that it might be interesting to see where this goes in the future. But for now, the definition of medical necessity with regard to ambulance transports is all other means of transportation contraindicated. So if that patient could have safely gone by any other means, medical necessity doesn't exist. The next one's reasonableness, and that really gets at the issue of why did we have to move the patient. Now, reasonableness is most commonly an issue with non-emergencies, especially inter-facility transports. And sometimes the difference between medical necessity and reasonableness is a bit muddy and hard to grasp. But basically it's this. Medical necessity gets at assuming the patient has to be moved, why do they have to be moved by ambulance? And reasonableness really gets at the issue of why are we assuming the patient has to be moved? And so both of those issues must be clearly supported by the documentation in order to have a payable claim. Next, of course, the patient care report. And again, that's the primary document that's going to be looked to determine whether the requirements of the claim were met. Simply documenting a list of things we did to the patient without any justification for the intervention or patient's response to the treatment is just not good enough. The PCR needs to paint a clear picture of the patient at the time of transport and why ambulance was the only safe and reasonable means of transport. In other words, instead of the old black and white picture, we want a crystal clear Technicolor picture from those patient care reports. Subjective conclusions about patient condition are simply not good enough. The crew's got to document objectively what they observe and avoid personal opinions and unsupported conclusions. And just as an example of objective versus subjective, the statement, patient is intoxicated, is going to just lead to a series of questions. What makes you think that? And why did you assume that? Where if the documentation stated the patient has noticeable odor of alcohol in their breath, both eyes are bloodshot, the patient admits to drinking 6 beers in the past hour, you know what? Everybody, including the auditor, will come to the conclusion that the patient was intoxicated. And so that objective statement is so much better than, the objective statement than the subjective conclusions. So also, along with that, whenever possible, be both quantitative and qualitative. And here's an example of that. Patient describes pain as sharp and stabbing. Patient rates pain an 8 of 10 on a scale of 1 to 10. We've got both qualitative and quantitative documentation there. If it simply said patient had 8 of 10 pain, it'd leave you wondering, well, what do you mean by pain? What kind of pain? Where's the pain? And on the other hand, if it simply said patient reports sharp stabbing pain, well, the first question is going to be, well, what do you mean by pain? Is it bad pain or little pain? Or so again, both quality and quantity documentation of things like pain. It's the documentation on the PCR and not somebody in the billing office that determines who gets billed and how much. And I think that gets lost too often. The field feels like billing's not my job, but doesn't realize that, yes, but if the field doesn't do their job excellently, billing doesn't have a chance. Internal consistency. Make sure that your patient care report doesn't contradict itself. After you write it, read it. Make sure that it's internally consistent between different sections and different crew members. And if there's inconsistencies, recheck it. You know, some of the stuff we see really leaves you wondering, does anybody actually read this stuff? Here are some statements. Now, this all came from one PCR that we recently saw. It says the patient's awake, alert, and oriented to purpose and place, time, and event, no neurological deficits, equal grip strength, able to articulate sentences, normal speech pattern, vital signs, normal limits throughout the course of our treatment. What kind of a picture do you have of that patient? And yet later in the very same narrative, patient is confused, combative, lethargic, or comatose. Really? Now, setting aside for a minute the inconsistency of that statement with the rest of the PCR, that one sentence is inconsistent. Folks, your patient care report's not multiple choice. Which one is it? here. Any one of these four conclusions needs to be supported by the facts that the crew observed that led them to that conclusion. It was another PCR, patient position, prone or supine. They must have forgot the cot straps. I guess the guy's flipping around from one side to the other. You know, which one is it here? And again, patient care report's not multiple choice. This one I particularly enjoyed, in a sick sort of way, I guess. A cardiac monitor was not applied. EKG shows normal sinus rhythm. Well, you better check the monitor. And it reminded me of this little cartoon that I had seen. Readings look good, but maybe the monitor's got a problem because we've documented we didn't even hook it up, and yet we're getting a normal sinus rhythm on it. Once the PCR is completed, both crew members should read it and sign it. We feel pretty strongly about that. It is the job of the crews. In addition to the protection you'd get in an audit, it just helps make sure that errors are eliminated. And don't forget, quality assurance begins in the field. Now, those types of narratives are most frequently seen, frankly, when using an ePCR solution with some type of auto-generated narrative. Auto-generated narrative can be a good tool when it's used appropriately, but it can also make you look pretty foolish when you just let the machine do your job. Don't forget, the machine didn't see the patient, you did. And each crew member on the transport needs to take responsibility for everything on that patient care report. That auto-generated narrative, like I say, can be a great tool, but it's just that, it's a tool. The human still needs to read it and correct it and make sure that the patient care report accurately reflects the patient that you saw and treated. This is not where you want to be in front of a judge or jury. But, Your Honor, I didn't write that. The computer did. Trust me, you don't want to be there. Patient signatures is another one. And, again, we could spend probably the entire hour going through the signature roll, but we won't do that. We've got it documented here for you. It's out of 42 CFR 424.36, the general rule. We have to have the patient's signature unless they've died. And it then goes on to say that if the patient is physically or mentally incapable of signing, then there's another list of people that can sign. But don't forget, this is the test. Beneficiary physically or mentally incapable. So this list of folks that can sign isn't just a multiple choice list of take the easiest. It does have to flow through in order. So once you've got the beneficiary incapable of signing, we're all familiar with the B1 through B6 options, hopefully. And what that is a list of other people that can sign on behalf of the patient when the patient's unable to. This B5, I want to take just a minute to say something about this because this one gets misinterpreted sometimes just because of the technicality of the word provider. B5 says that a representative of the provider can sign a claim under certain circumstances after making reasonable attempts and all that. Understand that this B5 applies to hospital-owned, hospital-operated ambulance services only. That's what the word provider means. The rest of the ambulance services in the world, the majority of ambulance services are suppliers, not providers. So don't anybody take this one as a newfound, I didn't know about that one, and think it applies, because for most of the people listening, this does not apply. Again, it's hospital-based, hospital-owned only. And then B6, just a few words about this one. This is the one that makes it possible for the crew to document patient was mentally or physically incapable of signing, no other authorized signers available or willing. The crew signs that statement at the time of service and gets the signature of the receiving facility, perhaps, and that meets the signature requirements. Well, sure it does, assuming all of the conditions have been met. Condition number 1, patient was mentally or physically incapable. And none of the other signers were available or willing. And in both the case of the patient and the other signers, this is not it was inconvenient, I chose not to ask them, I didn't want to bother them, That's not the standard. It's incapable and not available or unwilling. This is probably one of the things that we pay a lot of attention to in claim reviews, that we see sometimes way too much reliance on the B6 exception. And it's so much so that we, in recent, within the last year or so, probably a year and a half maybe, have started tracking, as we do claim reviews, what's the percentage of B6 signatures? Not just were the signature rules satisfied, but how much of it was B6? Just so that we can get a feel for, are the crews trying to get signatures, or are they assuming that they can just check this one off with that B6 option? And I got to tell you, there's a long story I'd love to share with you. We don't have time today, but I can tell you there's a crew I've been working with for about 3-4 years now that when we started out, their signature compliance was horrendous. We do quarterly claim reviews for this client. I do annual training with all of their crews, and it's a large service, good-sized service. We recently did a claim review for them. Their signature compliance was 100% on their claims, and their percentage of B6 signatures, 0%. Their crews got a valid signature from somebody on 100% of their transports. Now, that doesn't happen every quarter. Certainly that's not possible on every single claim. There are going to be some B6s, but I tell you what, it ought not be 80-90% of your signatures. That ought to be an exception rather than the rule. And we've got several slides here that just go through the B6, all of the requirements to meet that. The important things here on this slide, the statement by the crew member that the patient was mentally or physically incapable, nobody else was available, that must be a contemporaneous statement. In other words, this is not something that you can go back to the crews the next day or whatever and oh, you forgot to indicate whether the patient could sign. If this isn't done at the time of service, that option's off the table. So just be aware that is a contemporaneous requirement for the crew's signature. And one other point that I want to make regarding the signature of the receiving facility. I think there's a great opportunity that sometimes is missed on this one when you have to resort to B6. And that is the signature from the receiving facility. There are many states where by state law the receiving facility, a representative, has to sign the patient care report just as a continuum of care, basically accepting the responsibility for the patient. If you happen to live in a state where that's the case, where every PCR is signed by a receiving facility rep as accepting the patient, understand that that's number one on this list of other acceptable documentation. So basically, you have the second half of B6 on 100% of your trips. The thing that would be critical for you is to make sure when it's necessary that your crew does their part at the time of service. And then that all came out of 424.36. There's a couple of things, of course, that we have to be aware of in the next section of the regulation, 424.37. And this talks about whenever anybody but the patient signs. And so this is the B1 through B6. Whenever anybody else signs for that patient, the individual signing must also provide a statement that describes their relationship to the beneficiary and explains the circumstances that makes it impractical for the beneficiary to sign. And so from our website, you can download a sample signature form that we have available there. We're not going to go through that in the interest of time today, but you'll find that on that signature form, whether it's a Section 2 or Section 3 signature, whether it's the B1 through 4 or 5 and or the B6, there's a line there for why was the patient unable to sign, and also the relationship of the individual to the beneficiary. That's because of the requirements of 424.37. So bottom line on signatures, the signature is always required for Medicare claims unless the patient's died. That's another important one that sometimes folks miss. If you have a whole bunch of claims that you're holding for a patient because you haven't been able to get their signature, this doesn't mean that the patient had to have died on a particular trip and then you can submit that trip, but rather once that patient is known to be deceased, any claims that you have holding for that patient that are still within the timely filing period, of course, can be submitted. But the big point here we want to make is signatures ought not be the job of the billing office. That's something that can easily be complied with at the time of service on 100% of your transports. And frankly, it's time that we just quit accepting the excuse that it's not my job. It can be done. It can be done very well. We've seen several organizations that do a fabulous job of this. And so if you happen to be in an organization where you're still hearing that we can't do that, it's time to have some training and a good heart-to-heart, because it can be done and it needs to be done. Crew signatures. I mentioned a little bit ago when we were talking about the PCRs and the auto narrative and so on that both crew members should sign the PCR. Now, is that a law in all this? Well, not in black and white so much, but some of the MACs have started kind of giving some indication that they're maybe leaning in that direction, and what they use is CMS Transmittal 327, came out back March 16th of 2010. This was not an ambulance-specific transmittal. This was the one that dealt with signature verifications, and it's when we started hearing about things like attestation statements and signature logs and all that. Well, that came out of this transmittal. CMS in this transmittal directs contractors to disregard any medical documentation in which signatures and credentials can't be verified. And what they're saying is those that must sign is anyone who orders or provides service. And so when you look at that from an ambulance standpoint, well, who orders or provides service in an ambulance realm? Well, the ordering is probably going to affect things like our PCS forms and so on. Who provides service? Well, why wouldn't that be the crew members writing their patient care reports? And so Transmittal 327 says that if any medical record is unsigned, it doesn't count. And so our concern, again, you will not find a law that says all of the crew members have to sign PCRs, a federal law. There are some state laws, and if you have a state law that says that, certainly that is the law in your state. But even where that's not state law, best practices would say that anyone providing medical care to the patient signs the document. Because what can happen if they don't is the reviewers may say it's not a valid medical record. Medicare already requires the PCS be signed, but this transmittal could arguably indicate the PCRs have to be signed by all the crew members as well. And so just because that's a possibility, we say it's a good practice, and best practices, certainly any crew member involved in patient care should be signing the patient care report. And it gives you a great opportunity to look at what's on there and make sure that it's accurate. And so those silly statements that we saw as we were looking at it earlier, you know, if both crew members would take the time to read it, hopefully one or more would say, this doesn't make sense. And yeah, good, let's make it make sense. And then once we're all happy that, yes, I'd be happy to stand in front of the judge and defend this one, then we'll go ahead and sign the patient care report and be done with that. So then just a few issues now we're going to look at. Those were issues that are just generally true of all trips. We see those not necessarily specific to either emergency or non-emergency transports. Now we're going to look at some things that are specific to one or the other. And we're going to look at those different periods of control that we talked about and some of the documentation that's necessary during those different periods. So with regard to emergencies, what about the dispatch phase? Well, this is absolutely critical in the case of emergencies. And of course, the first step is to have clearly understood and consistently used dispatch determinants in the dispatch center. But it's the documentation of the dispatch that tells so much and determines whether a claim is accurately billable as an emergency or as an ALS. in the case of an ALS assessment for an emergency. The things that we need to know from this, first of all, was it a 911 call or the equivalent? That's part of the definition of emergency. Also, what was the patient's reported condition at the time of dispatch? Was an emergency response medically necessary, and was an ALS response medically necessary? All of that is really determined through the documentation at the dispatch phase. And then the response phase, the patient care report basically needs to verify the stuff that was documented in dispatch, that this is in fact what the crew heard and was responding to. Was it a 911 call? Was an immediate response requested, and was it provided? Was an ALS response medically necessary? And if so, was it provided? Or was this a case where all of our ALS ambulances were tied up, so we sent an ambulance with only 2 EMTBs in it? Clearly we can't have an ALS assessment at that point, no matter what the patient's condition is. But independent documentation by the crew of the dispatch determinants and response times and any delay reasons, that immediate response, let's take a look at that real quick here. This is the definition of an immediate response, but look at the application there. The determination to respond emergently must be in accord with local 911 or equivalent service dispatch protocols. And so it's the protocols in dispatch that determine when an immediate response is requested. Now, your PCR documentation will show whether you provided it or not, but shoot, we could have a case where a call came in to respond to the hospital, take somebody back to a SNF, and because we had nothing else going on, we went right away. Is that an immediate response in the context of an emergency? No. It's the reasonableness of the dispatch, as pointed out here in this application, that determines whether an immediate response is requested, and then your documentation will indicate whether one was provided. And with regard to the delays, there's no number of minutes on this. As you read the definition of immediate response here, it does not say responding within X number of minutes. It just says that you began as quickly as possible to take the steps necessary to respond to the call. So if you're in a situation where system status overload, all of the trucks are busy, but we went as fast as we could and we've documented the facts of that delay, that can still qualify as an emergency response. Okay, the patient care phase then. The patient care report, obviously here, is the primary document of this phase as well, and needs to document the description of the emergency. What were the events that led up to this patient calling for the ambulance, and then a clear picture of patient condition at the time of transport, any medically necessary interventions, and the patient's response to interventions. That's one of the things that I think in the years ahead we're going to see a whole lot more interest in patient outcomes and documenting whether or not what we did for the patient actually made a difference. And one of the things that I think we, as an industry, need to get better about documenting, not only what we did, but why was it necessary and did it help? With regard to the ALS assessment, notice again that dispatch indicates when an ALS response is necessary. In the definition of the ALS assessment, it says it is an assessment performed by an ALS crew as part of an emergency response. Okay, so it clearly does not apply to non-emergencies. Part of an emergency response that was necessary because the patient's reported condition at the time of dispatch was such that only an ALS crew was qualified. And there's an application that goes with this one too that makes it abundantly clear. The determination to respond emergently with an ALS ambulance must be in accord with dispatch protocols again. So it just keeps making it clear that if you're in an organization that says, well, we don't really have dispatch protocols, we just kind of get dispatched to respond and don't necessarily know what's going on, that's a bad place to be. Now, I understand there are plenty of services that unfortunately your PSAP dispatches you and you have no control over the PSAP. I understand that that happens. As much as you can, you need to help them understand that that puts you in a tough situation with regard to accurately documenting the entire life cycle of the claim. because they say that where no protocol is used, the patient's condition on scene determines the appropriate level of payment. And unfortunately, this is usually going to result in more claims needing to be billed at the BLS level because we didn't document a medically necessary ALS dispatch and ALS assessment. And so you're really leaving money on the table in many cases by not having good, accurate dispatch protocols. And there's the citation of the manual if you want to go back and look the rest of this up after we're done here. Another one that we run into is we sometimes hear crew members say, well, my job's patient care. Okay, I agree. So let's talk for a minute about the definition of patient care. Just like it wouldn't be okay to provide excellent medical care but abuse the patient emotionally, something I would assume we would all agree is not okay, it's also not okay to provide excellent medical care and abuse the patient financially by shifting financial responsibility to the patient for services that should be covered by another payer but won't be simply because the crew did a poor job of properly documenting the facts of the transport. Good patient care involves financial responsibility for the patient as well. Probably the two biggest, or certainly two very big areas of concern associated with systems that are all 911 are these, either all emergency billing or all ALS billing. And we'll hear statements like, well, we're all ALS or we're all 911, everything's an emergency. And I have to kind of chuckle when I hear that because the thought that always comes to my mind is, really? Most places I've been, people dial 911 for stupid reasons sometimes. And you're telling me that no one in your community dials 911 for stupid reasons. Probably not the case. And so just make sure that we're aware of the requirements and the definitions of both emergency and ALS. You've all seen the news, I'm sure, of services that have gotten into multi-million-dollar problems over some of those habits. And again, in the billing and AR management phase, make sure that the documentation is present to make the billing decisions that you have to for every claim. If something's missing or something's incomplete or something's not clear to you as a biller, then you don't have the documentation you need to process that claim. And an attitude of, well, this is what I got, I'll have to run with it, is a huge compliance risk to the entire organization. Billers need to help the organization with their compliance efforts by making sure that claims billed for reimbursement have all of the documentation that they need to comply with the various requirements of the different levels of service. If the documentation clearly shows that coverage criteria is met, then by all means, get every penny you're entitled to. It's your money, go after it and go after it hard. Also, if the documentation clearly shows that the transport does not meet coverage criteria, well then don't try to obtain reimbursement that you're not entitled to. We go after the right payers, and the GY modifier comes into play here. If we have to bill Medicare for something that we know is a non-covered service, then by all means put the GY modifier on it, make it clear, dear federal government, I'm not trying to get federal dollars, I need the denial from Medicare so that we can go after the appropriate payer. And so if that's what the documentation shows, great. If it's clear, wonderful. That's what we needed to know so that we can bill the appropriate payer. But if the documentation's unclear as to whether coverage criteria is met or not, then you don't have what you need to bill the claim. Get that documentation before you bill that claim. So what do we need? Well, all of those things that we talked about earlier and a few more. We've got to know that medical necessity is appropriately documented if in fact the transport was medically necessary. Again, reasonableness, if in fact that's the case. The appropriate level of service, make sure that we're billing based on the requirements of all the various levels of service. Make sure we're using appropriate location modifiers. Sometimes we see some problems here between N, skilled nursing facility, and E, the assisted living type, and also sometimes an R versus an E. You need to use the modifier that is the most specific and most accurately describes the places where you pick the patient up and drop the patient off. Also appropriate second modifiers, and that's things like your GY, your GA, GZ, QL, GM, all of those. QJ, interestingly, that kind of came up in the last few weeks here with the incarcerated individuals. But those second modifiers, make sure that those are being used appropriately. Appropriate ICD-9 codes. This is still one of the areas that when we go around the country, we sometimes see folks spending way too much time laboring over putting several different ICD-9 codes on the claim. Based on the instructions that came with the condition codes, typically one code is what's necessary. Now, we say here ICD-9s, and I guess that gives an opportunity to make sure that I'm sure most of you are aware by now, but if you're not, ICD-10s supposedly are coming October of next year. And so that's something that you're going to be hearing a whole lot more about. In fact, at our ABC3 conference in Hershey this fall, we're going to have a huge emphasis on ICD-10 codes and helping the industry get started on some of that. Billing narrative. Make sure that the billing narrative accurately reflects the documentation and supports the level of service billed, and then fractional mileage. This has been a requirement for the last couple of years now. Make sure that fractional mileage is properly documented and billed. And then signature requirements, both the assignment of benefits, the patient signature, as well as crew signatures. And those are the big areas that we typically see issues with regard to emergencies. And now some issues common to non-emergency claims. Call intake phase is a big one here. Sometimes I think that things like the PCS and the ABN and even signatures to some extent are unfairly, in my opinion, made a crew responsibility when really I see that as a function of call intake. This is a time where we've got a patient, it's not an emergency, we've got a patient or the representative calling for transport at some point in the future. We know we're going to need a PCS. Sometimes we know we're going to need an ABN. We know that we're going to need to know who the payer is. You don't walk into a doctor's office and see the doctor without giving them your insurance card first and so on. So, I mean, people are used to that with regard to other types of medical care. Those are the kinds of things that, frankly, call intake is the time to be handling those kinds of issues. With regard to the PCS, is the PCS properly completed? Does it document medical necessity? Is it signed by somebody authorized to sign it? There's a specific list of folks who are authorized to sign a PCS. And again, we're not going to go through all the finer points of all of these issues because I think hopefully you're all familiar with them by now. But the thing that we still see too frequently is either an LPN or a social worker signing a PCS form. Those are not authorized signers. Is the signature verifiable? And are the credentials of the signer there so that you can tell whether this is an authorized signer or not? Is the PCS dated and valid for the date of transport? And in the case of scheduled repetitive, for example, is it in hand prior to the transport? It's a requirement for scheduled repetitive, it's best practice for others as well, but do we have the PCS form signed, valid, when we need it? During the response phase of the non-emergencies, some of the things, just like with emergencies, we have to have the zip code of origin, origin and destination types, and that gets to the modifiers again. Documents loaded miles to the 10th of a mile. One of the most common problems that we see, especially with regard to scheduled repetitive, is unfortunately what it boils down to is laziness, and probably due to familiarity with the patient. What crew members and their organizations need to understand is that every single transport needs to be documented as if this was the first and only time that crew saw the patient. That patient care report, if it's pulled for audit, needs to stand on its own, and accurately document patient condition. And you know the example that many of us in the industry talk about and laugh about, but it's sad how many times you see it, frankly, is someone with amputated limbs that on Tuesday they have them and on Thursday they don't. And then on next Tuesday they grew back again, apparently, based on the documentation. That's just the kind of stuff that needs to not happen. Also, medical necessity for ambulance transport, and that clear picture that we talked about. Patients' ability or inability to assist with their transfer to the stretcher, and documentation of their ability to perform activities of daily living, and so on. Good, clear documentation. For your scheduled repetitives, we've got a complete evaluation form and process that we recommend that not only the ambulance crew on the date of service, but your organization needs to be really carefully documenting whether those scheduled repetitive patients need to be in an ambulance. Medical necessity for the various levels of service. The documentation, again, it comes back to the crew's documentation, determines level of service that we can bill. Reasonableness of the transport, especially for interfacility transports, is a big deal for these non-emergencies. What specific service does that patient need that's not available at the origin? And why did they need it? The time that this is especially important is when they're in a facility that frequently does offer this kind of service, but today maybe the specialist isn't available, they have no beds available, whatever, but for some reason they have to go someplace else, but this is unusual. Medicare is, of course, going to look at that and say, well, that facility does that type of work, and so in those cases, it's so important that this be documented as to why that patient had to be moved. And again, the issues that we talked about with regard to emergency in some cases, taking care of the patients medically, emotionally, and financially applies. Make sure that all the documentation from the billing, again, is there. And with non-emergencies, there's more paperwork to look for. You've got to be looking for PCS forms and sometimes ABN forms and so on. Make sure that we have all of the documentation to support that claim that we're going to be sending out, and help our organization ensure their organizational compliance by making sure that any claims that we bill for reimbursement have the documentation to back up the level of service that we billed. And this is a repeat of what we said before, but it is so important. If you've got good documentation that supports billing for that transport, by all means, get your money. If it's not there, don't go after money you can't get. But the important point is this one. If you're not sure, that's not time to just throw a claim out at Medicare and see if they decide to pay it. That's where the real risk is. If you don't know, it's not time to bill the claim yet. We've got to know all of these issues that we already went through. And while we're on non-emergencies, just a quick little reminder, hopefully this isn't new news to anybody doing these types of transports, but effective October 1 of this year, the fee schedule payment for non-emergency BLS transports of dialysis patients to and from their dialysis is going to be reduced by 10%. And if that's a transmittal that you've not seen and you want to read the whole thing, there's the transmittal number, came out back in May. So in wrapping up here, there's several opportunities for checks and balances within an organization before any claim is submitted for reimbursement. And compliance with the requirements during every phase of a claim's life cycle is absolutely vital to the survival of your organization. We just need to keep in mind that that claim, the life of a claim begins when the phone rings. And as that claim develops through the process, everyone involved in what's eventually going to turn into a claim, especially for federal dollars, needs to be doing everything that they can to help their organization ensure compliance with all of those rules. Here's an opportunity for me to tell you, if you're not already on our mailing list, you can go to pwwemslaw.com and sign up for our bulletins. And as things happen, as for example, that dialysis reduction and so on, we send email blasts out to the industry to help you stay up with all of the different happenings in the industry. And now I'm going to turn it back over to Kathy for just a minute here.
Steve, thank you for sharing these insights. We welcome your feedback and have our contact information here. We'll put up on another slide. The next one. And we'd like to thank everyone today for joining us, and we wish you all to have a great afternoon. Thank you.
Thanks, everybody.